Right, let's make sure we're on speaker view to gallery view. Right, welcome to Protrusive Dental Podcast, gents. We've got Chris O'Connor and Alan Burgin today. Now, just want to set the scene for those people who'll be listening on the podcast, because that's the bulk of you, that's the Protruserati. So this is all about centric relation. Now, we've talked on previous episodes about the why and when to use centric relation. So it's sometimes nice to touch on that, but I don't want to delve in too deep into that. Today is more about the how. And I remember going on the Dawson Academy, and I know, Alan, you've done Dawson as well. The biggest issue, the biggest barrier people had, every single module we had was that, hey, I'm still kind of stuck recording centric relation. So I think it's going to make for a great episode today. And with me, helping me talk about this topic, I've got Chris O'Connor and Alan Burgin. Chris, please tell us a little about yourself, what you're up to, where do you work, what your interests are in dentistry.
Yeah, Jazz, I'm a big fan of the show, so it's pretty exciting to be on, to be honest with you. Not that great at public speaking, so we'll see how it goes. But yeah, I'm a restorative dentist, and I graduated 2008, and I worked in practice for quite a while. And then probably later than most, I went into academia, and I've been doing my PhD for the last, I don't know, quite a long time. And I
What's your PhD
in? Well, I ended up doing clinical trials with 3M. Actually, it was a product that they brought out, which was like a novel composite crown, like a chairside one. So we did a clinical trial and some tests on marginal fit, and yeah, I'm just finished all the experiments. I'm writing that up right now for my PhD. And so I've done that for ages, and then all the time ever since I graduated, really, I've been teaching, and I had a load of courses in the Northeast I used to do for Health Education Northeast over quite a long time, and also teaching at the university, both undergrads, and then the last few years, which is where I've been doing a lot of CR records, is on the master's program, teaching postgrads there. So a huge lot of CR record teaching, actually.
What do you think? Would you agree that that's what students struggle with? Like your master's students, do you get that feedback that, hey, you know what, in practice, I'm struggling with this area? Would you say that's true?
I'd say it's what I struggled with, Jazz, when I had to start teaching them, because you learn all this CR stuff, you go on a course and you do it on each other, and you've all got all your teeth, and it's, you know, a fairly standard situation, and you come up with these techniques. And then the difference at uni is we teach chairside. You know, we have the patients in, we have incredibly challenging patients, and we're doing it right there, you know, and what you find out about CR records is there's lots of techniques, but you actually need to troubleshoot and become proficient in several and be able to pick a mix, which is the best way to go. And I think as I've been teaching them, I've been learning, you know, with them. And that's always that's always the reason you teach and you love to teach, really, is it helps you learn.
That's a very humble of you to say that.
Yeah. So I've just learned so much in the last 3 years, because I need a technique when I teach it that not only can I do, but they can do, everyone can do. You know, there's no point teaching techniques that only 2 people in the world can do. It's like, is it predictable? Is it reproducible by anyone? And that's what I'm looking for.
Amazing. Now, before we get to Alan, I just want to tell the listeners that the first time I was ever exposed to Chris O'Connor was a lecture. It was like a young dentist academy. I don't know what it was, maybe 2013, 14, maybe 6 years ago now. And your lecture title was, "Are You Isolated?" Right? I don't know if you remember, it's "Are You Isolated?" And literally I was here and I thought this lecture was going to talk about like depression in dentistry, but I was so happy you talked about rubber dam. And it was just the most amazing lecture. And since then I've been very much isolated. So Chris, thank you for setting me on that path of isolation. Back then you had a lot more hair, obviously the PhD done something to you.
Yeah, that's right. I mean, the rubber dam stuff, back, you know, I think Zach, who was on your show, I was listening the other day, he called me the Og with the blog. I had to look it up. Og with a blog. You know, I used to have like a website, and we used to talk a lot about rubber dam, but it wasn't like it is now, where there's so many people are so good now. You know, you look, it's incredible. We were all fumbling around trying to work it out with terrible clamp selections. You know, now it's just amazing what people are doing. Dentistry is forward so fast in this country. It's amazing.
And speaking of fantastic isolation rubber dam, who other but Alan Burgin, aka the Cornish dentist. Alan, you have a whole episode, man. You have a whole like 1 hour on Producers on a Podcast. This is far too unfair. But can you please tell everyone a little bit about yourself before we dive right into the nitty gritty?
Yeah, sure. My name's Alan. I'm just a general dentist. I'm very much a generalist. I have an interest in implants, but yeah, like you, Jazz, very much a generalist, just because I quite enjoy it all, really. And like you, I did some training in occlusion at Dawson, and I think you hit the nail on the head, really. Everyone comes away going, yeah, I think I manipulated that mandible to where it's supposed to go. And that you do have to just learn a little bit as you go along. But equally, it's about opening to all the methods and availability as to how you can record that. And that's kind of the position I'm in now, where I've tried out a few different techniques and can really sort of found the sort of methods that work well for me in my hands.
So it's all about those different methods today, about how to get a reproducible method, something that's easy for the dentist to use, but something that's actually going to be accurate. And before we get to that, two little disclaimers, right? Two little disclaimers. One is we're not specialists. We're just general dentists. We're just humble GDPs, generalists. I think Chris has got more accolades and letters next to the name than me and Alan put together. But we are just humble general dental practitioners. We're not prosthodontists, so bear with us because we're still on our journeys as well. But secondly, is that centric relation is not a position that we use in GDP land. I mean, the first question I'll probably ask you to is, what percentage of your patients are you working in CR, right? Because for me, it's probably 5%. 95% of dentistry, 95% is still, doing the single tooth, the two teeth, even sometimes a quadrant, but I'm still conforming. So Alan, what percentage, I think it'd be a bit higher for Chris, but Alan, what percentage of your patients, but then again, I just remembered, Alan, you do see a lot of edentulous, I think. What percentage do you see that you restore to within centric relation? When is that relevant for you?
When it's relevant, yeah, I would say maybe 5 to 10%, but actually restoring in CR maybe, closer to 5, because sometimes you just need to find out. First of all, you want to see where their centric position is. And yeah, I have quite a few edentulous patients that come to me looking for implant options, but actually once they find out a little bit more, then they might want just a really sound denture. And so that was sort of one of my pathways into how I found out about some of the methods we're probably going to talk about tonight, because I sort of had these cases of going, okay, these people couldn't necessarily afford, or implants weren't right for them, but they do want a decent option. And so these edentulous patients were, I was sort of looking at their positions in CR. Sometimes it was a case of getting them into articulated models, having a look, and then deciding which way you're going to go. But yeah, not a huge percentage.
And Chris, before I just ask you, if anyone's sort of thinking, hey, you're at that journey where you think, when do I even use centric relation? Why is it even needed? I'd go back to episode 20 with Kushal Gadia, which we titled, If You're Not in Centric Relation, You Will Die. It's a bit of tongue-in-cheek episode title. So check that one out. Today was very much about the details about how to do it. But Chris, you're an educator. You're teaching master's students. Therefore, on your clinics, you are referred patients with more complex needs. I imagine that percentage is much higher for you.
Yeah, almost every case we're doing on the master's course is a rehab. And if I can just like a tiny bit on why you would do it, because I think it really is important, respecting that it has been covered to a certain extent, it's just this idea that CR is a position of restorative convenience. I don't put anybody in CR to get rid of muscular pain or to solve jaw problems. And I actually think, I listen to Jazz talking on the podcast, and I think he's much further with me in terms of managing parafunction, way further on his journey. That's not really my thing so much. And it's never am I putting someone in centric relation because I think, that's going to be so easy for them. The reason we put them in it, is because in that position, that special position with the jaw fully seated, the jaw acts like a hinge for that first, 20 millimeters of opening. And that's the magic number. That first bit of opening, it is on a hinge. And because it's on a hinge, we can predictably open up and know where the patient's going to go. In any other position, we just can't predictably do that. And so it's a cornerstone of planning to get that position right. And as we're going to talk about, why is it so important? Because if you're a couple of millimeters out or a little fraction of a millimeter out with your CR record, by the time you open it up and you, multiply and compound the error, you are a long way out. And again, that's okay. You can spend hours adjusting the restorations and things. But a lot of the fundamental planning, am I going to need to equilibrate the patient? Where am I going to set them to? That planning is done on those articulated casts, and getting them right. And the only place we can articulate if we're changing from intercuspal, that we can get it accurate, is in CR. So that, I don't know if that is going over old ground, but that is why it's important. It's a position of restorative convenience.
I love that. And I think there are these schools of thoughts that say that, magical healing things will happen in centric relation. I mean, be careful what you listen to, but I think very much pragmatic restorative dentist approach is convenient for us. Let's put them there. It just makes our life much easier as well. But there's a few other things we could go into, but very much I want to just dive into it. So Chris, why don't you take the first part? Then Alan, you could take the second part and show some of your sort of techniques. And I'll talk about how incorporated digital into the workflow as well. So Chris, tell us, what are the most common ways that you teach on your masters? What have you found most successful? What have you found people struggle with more, or that you've actually completely given up? For example, bimanual manipulation. Do you guys use that to verify? Do you guys use it at all? You take it over. Share the screen if you need to.
So yes, it does. So I was taught bimanual. I think that was the only method I was taught as an undergrad, and I went through with it. And honestly, it doesn't work well for me in my hands. I've always really struggled to get that record, because the idea is, and if everyone's seen the pictures where you get the patient and you're kind of holding onto their chin with both hands, and you've got them supine, and you're trying to just relax them back. And then what you need to do then is close them into usually some wax record. And there's a couple of things. One, it's very hard to get that wax record to be stable against the maxilla when you close the mandible in. So it's a very difficult dance to have your assistant or your nurse holding that up while you're trying to move it in. Okay, so I find it particularly difficult part of that. The other thing that I find very difficult is the patient tends to fight against you, and it doesn't matter if you've got them in a lovely arc all the way up until your record. It's when you actually take it. So if they move even a little bit, you're stuffed. And then also when they hit the wax, when people hit something, they just press against it. The muscles go, and staying relaxed and just tapping them in is very difficult. Once they feel something between the back teeth, they're going to shift. So for all those reasons, I find the wax and the bimanual quite difficult. And then just to go further, when you go actually mount it, I mean, I did a big audit on this, checking them, and very often the wax doesn't quite fit. You have to flex it to get it to fit on the cast, or it's difficult. So there's an inaccuracy there as well. And then just lastly, as a teacher, I can't check if it's right. I can't go, yep, you bang on. And I have so little control that only do we find out when we're mounting them and doing all these things. So I think it was like I used to take it as a very personal failing that I couldn't get it to work. And therefore, because I didn't feel confident with it, I didn't actually feel that confident teaching it either, and that was a problem. So I suppose I was hunting for other methods. And of them, and actually even bimanual, just, to check someone, I find difficult. I prefer the chin point guidance. For me, I feel
I'm actually the same. I'm the same. I prefer chin point. I can just feel like
a quick check at the beginning of it. I actually just find I get them back easier there. I don't know. I totally take that in a lot of people's hands it works mint, and I'm not knocking that, but for me it's always been troublesome.
Alan, do you have much more success with bimanual?
I mean that's where same as you started. I was doing it routinely with a Lucia jig to try and control that closure and that last little point where they're hitting onto the wax, and trying to get that repeatability where you've looked on the Lucia jig, you've made your mark, and so yeah, trying to add in that little bit of predictability with where you know, or you think you know, that you're in the right spot that you checked before. But yeah, all the same problems Chris was mentioning. Yeah, I had some very similar difficulties. But yeah, that was where I started off, really.
Mm-hmm. It's interesting, Chris, that you said that you find the chin point much easier, because I've always been embarrassed to say that, but I can't believe you said that. I'm so glad you said that. I'll keep it under my turban. But Chris, please tell us what you think is now not necessarily superior, because as long as you get there, it doesn't matter how you get there. But what is an easier way? What is, in your opinion, a better way?
Yeah, so if you excuse me going on a tiny bit, on the journey, the next sort of thing I came across was using the leaf gauge, and the leaf gauge or feeler gauge is fantastic because, and Jazz, I'm sure you're going to hold one up. I know that you're a big fan.
So I have to speak so that, yeah.
And I think it was Stephen Phelan, maybe I first watched doing this, Frank Spear definitely, this idea you put these leaves between the front teeth and you get the patient to go forward, go back all the way and squeeze. And actually, because they've got no posterior contacts and you can spend a few minutes sitting on that leaf gauge, it really predictably actually moves them forward and back and gets them in centric relation. And you can load test as they squeeze on it. And you're like, hey, this is amazingly easy. And then what's great with the leaf gauge is you can then start taking the leaves out, keep going forward and back and squeeze, and you can generally find, especially if it's posterior, that first point of contact. And you're like, boom. So you've got your first point of contact, which you can use to check your records. Then you can slide in a few more leaves. And I think critically, you want to get enough leaves that you've got the thickness for your record. But also, and I know you've talked about this just before, is get to the height that you want to restore at. And I would say, yes, brilliant, as long as you've got the thickness for the record, which comes first. It's the most important. But then if you get it to the right height, that's wicked, because it means your face pose or whatever you use to mount the maxillary cast is less important. So the leaf gauge is great, and you start getting good results with it. And then if I'm doing that and I'm liking it, and then I kind of realize my friend actually starts talking to me about and I didn't really understand it before. I'm just going to share the screen here.
Sure.
And he explains to me about having a constricted path of closure, and constrict. So because for me, when I bite together, right, I hit my back teeth first and I slide forwards. And in my mind, I was like, well, that's what everyone does. They have a centric relation and they slide forwards. Okay. Well, my friend Ollie Bailey, who writes some papers, what he was telling me was actually that's not the only thing that can happen. Yeah. Some people have their first point of contact at the front of the mouth. Yeah. And you see them with, these deep class 2s and they have that wear going on. They hit at the front of the mouth on the incisor and then they are forced back. Okay. And I was like, what do you mean forced back? How can you get forced back? CR is like the most posterior point, and it isn't. And there's a reason that the CR definition is the most superior position. And that's because, and this diagram I'm showing you is from Dawson's seminal text, which I'm sure everyone's probably read who listens to this podcast, but this temporomandibular ligament is holding it in CR. And if you push someone hard enough or forceful enough, and you can do it on yourself. If I try and push my jaw right back, bloody it hurts like crazy, because what you're doing is you're pushing the jaw posterior and you're straining that ligament, and you can push it back, to a couple of millimeters. And what you find is that any technique which is directive, and I would class a leaf gauge as that, because you put it between and they go forward and back, and it's very easy. If I can manage to click on the thing, it's very easy to have that leaf gauge not at a flat angle and to have it steep and inclined. And what you can do if you're not careful is actually force that patient back past CR, and it's still quite reproducible, if you know what I mean, because you're like, that's as far back as it goes. So if you do it 10 times, you'll probably be the same place 10 times. But if you then restore them in that, they've got this constricted closure path, and it's really painful because they've got that ligament straining all the time. And so it was just a massive wake-up call to me that leaf gauges are wicked. I really like them. They're great for checking. They're great for equilibrating. But there is this class of patient, particularly the constricted ones, who are very high risk of pushing back because that ligament's kind of stretched and they're used to going there. So there's that kind of, you know, group of patients. But then just anyway, you can push someone too far back, and it's just a little bit of a thing that I came across. So I was doing leaf gauges, double records, and mounting, and then I came into this. I'm just where I'm up to. I'm just aware I've been talking a long time.
So Chris, no, that's fantastic. But let me, if you don't mind, let's have a healthy debate about this, because I've got a slide I'm going to show you where I'm going to try and argue with you. And actually, I do believe that you are right, that with the leaf gauge, potentially you can go too far back. But if you do it in a controlled way, that it shouldn't happen too much because of the following. So let me show you this. Okay. I think that that's a theory, what you said about pushing the condyle all the way back, and the fact that you can do it to your own mandible, fine. But if you look at the fibers of the masseter, right, and the direction that they run in, they are actually anterior to the condyle. So as long as the masseter's firing, it shouldn't allow your condyle to go too far back. So this is something that Barry Glassman taught me as just to counter that. So whilst I do accept that it does happen, and it can happen, and particularly in someone with a class 2 division 2, I think it generally, I like it. I like this slide because it sort of backs me up on it. But it's the fact that the angle of the masseter muscle is a little bit on your side, but I do accept that you can, especially if you get a patient to really bite together and they've got a deep bite, that they can probably override that. But would you say that this is an interesting point I've made?
Yeah, definitely. And it's not like it's that how predictable are the leaf gauges, I suppose, and you're like, okay, they're pretty snazzy, and I think they're really good for about, you know, I class people like easy to put in CR, medium, and hard. For the medium and easy guys, I think it's a really good technique. For your super hard ones, it's a little bit less predictable, I think. And there's this little subgroup you've got to be a little careful of, in my opinion. The other.
So what do you use on that? Yeah. So let's move the story forward. So moving away from leaf gauge, what else do you do?
Well, the only other thing with the leaf gauges is, and if we have, I'd like to talk about it, because what I've realized in the whole of my teaching is you go and teach these CR records, right? And then we mount all our own casts upstairs, and I generally sit with the master students and we'll mount them. And what I came to realize was the mounting is a massive part of this, right? It's a huge part because there's so much error comes in, you know? And so the leaf gauge, you can take the best records on earth, but you've got to get your mounting right as well. And one of the nice things about the leaf gauge is it allows you to put your, you put your leaf gauge in, you can put the silicone reg material in the mouth and bite together, and the silicone's on the teeth, so it tends to make quite stable wedges. So just as another thing that's in favor of leaf gauges, it's really good like that. They're on top, and it helps with the mounting. So yeah, so after the leaf gauge, what as a teacher, again, I suppose we were getting some variable results because maybe it's just a little bit of like one of those things you have to learn. And again, I couldn't necessarily check exactly where they were when they were doing the leaf gauge. And we take double records, and maybe I would take a record, you know, but the whole, we invest a lot of time when we wax these up, because again, the students will wax them up often with me. It takes a lot of time. Like, we need these right. So what I started to move on to was doing Gothic Arch Tracings. And Gothic Arch Tracing, I'm going to go share the screen again. Hold on.
So these tracings are traditionally for edentulous patients, complete dentures, but am I right that you're bringing this into dentate patients?
Yeah, that's right. You know, and it's not like a unique or singular idea. The Gothic Arch Tracing isn't particularly meant for, you know, there's extra oral ones and intraoral ones when you look in the literature in the old textbooks, you know. But the idea is that you basically have a single point, ideally, hitting a flat plane perpendicular. So you know, the picture I'm just showing here is this ARF mini reg, which is like one you can buy, and it's got a little point that you put on the lower, just doing this in case people on the podcast, little point that goes on the lower teeth and a flat plane that goes on the top. And then you can get the patient to go forward and back and in lateral excursions, and you should create this classic arrow tracing. And the nice thing with arrow tracing is you know where the lateral excursion lines intersect should pretty much has to be centric relation on that back point. And if this patient is going back and being constricted and constrained back, one, it doesn't happen very much because they're hitting a flat plane, so it's much less likely to happen. And two, you see it in the arrowhead because the arrow's got like a bit that's going past the two lateral points. So so these Gothic Arch Tracings, what's great as a teacher is it's an amazing learning tool because the students like learning where they should be. Mm-hmm. And also I can go, right, yeah, that's it, where the point's at the back. Brilliant.
It's visual. It's so much more visual.
Yeah, you're definitely right there. Look at your lovely arrow. Now I want you to record it there. Okay. So this is this AFR mini reg, which is one you can buy. And the technique that I think I have slightly developed, I haven't seen it published, but this is what I do. And just to go back, we were taught these Lucia jigs at undergrad, but you used to make them out of like Duralay or Dinar de Program or anything like that. And the problem you have, right, is that the lower teeth don't have a single point. So you could never do this Gothic arch tracing. And I remember getting this weird seminar where we were like taught you had to grind it away to make like it hit right. And it's just impossible. You can't get it because the lower teeth are generally flat and they'll contact across all 2 to 2, you know? So you could never get this arrow that you were aiming for. I never thought it worked. So what I sort of decided to do was get some flowable composite, no etch and bond, and basically syringe it around the lower incisors and make like a little point, like a little divot that came up, put a Dinar deprogrammer with just some silicon bite reg on the top, and then, you know, choose your poison to put a marking on the Dinar deprogrammer, and then the patient can trace forward and back, and you can make that same intraoral tracing. And it's great, you know, you can be very confident that you're in CR. There's a couple of downsides with this technique. One is that it's really nice because you go forward and back and you can get them to that back of the arrow and you can see the back of the arrow, but then you have to gun the registration material through the sides, really. If you try and put it on the top of the teeth and then do the forward and back and check where they are, it's quite difficult to kind of get them, be sure they're in the right place. And that's why, and Alan will talk about this better than me, but when you do it for dentures, you tend to have like a little, almost like a little locator that makes you bite into that point.
Right.
They get like a little a plastic disc that you wax onto the back of the arrow.
But Chris, could you not do that? So once you get your patient to describe to the audio listeners in the podcast, flowable composite, little blob at the bottom, lower incisors, you got a flat plane at the top, and the patient bites together, and now they're skating around, right? And they can deprogram, and you can get your recording. But Chris, once you verified that every time the patient bites together, that they're biting together at the same beautiful spot, and you are happy that, hey, I found my centric relation, have you considered ever just getting a burr and just drilling into the upper member a little bit, allowing the little bit to just slot in just a little bit?
Yeah, I've tried a few things. I tried like putting a bit of composite on the top and then like almost gluing them together, but that was obviously a bit of a not a great start. You know, I looked at a few things. I think when you put a divot in, they're going to close from where they were, you know, just slightly, and that might shift them out. I mean, I'm open to trying. I mean, this is, I'm sure all great ideas have been had more than once, but definitely this was something I've been working on because I wanted to,
Very
be able
good.
to do it
Very good.
easily. And I didn't actually know about those AF ones before. I don't mind if you take interstitial records where you've gun the VPS in, it's still, as long as you've got a good mounting protocol, and I've become pretty obsessed with mounting protocols for the last year or two, getting it like accurate every time. As long as you've got a good mounting protocol, you can get that right, but it's just a little bit more fiddly. The other problem with this setup, and I love it because I think as a teaching aid, it's just fab, and I think it's really predictable, and I just really think it's a good way of doing it. But the other problem you've got is just whether you get past that 20 millimeters of opening when they're still in CR. And you've just got to be a little careful because by the time you've got your DNR in and your flowable on the lower, they're going to be a little bit more open than you get with a leaf gauge. It's less optimal for getting that, you know, that height that you're saying, I want to restore to here. And you don't have that option either. You're kind of going to restore to, you're going to get them where they are. And I don't think it's a problem. You know, I think if you had to say how important for your records is CR records, it'd be like 95%. How important is the FacePo, you know, the Cois, we use the Cois dental facial analyzer, it's like 5%. you've got a lot of margin there before it makes a big difference. But even then, it's obviously preferable to record at the height you want. So they're the downsides.
Can I just stop you? And I want to just ask a little bit more about this technique, because now you've raised a very interesting point that actually, if they have this little composite at the bottom and they've got this jig at the top, that their opening could be much more than what you'd like potentially, right? But in this scenario, imagine the patient had 100% overbite, i.e. the upper incisors are overlapping all of the lower incisors. You don't see any lower incisor when they bite together, right? In that situation, you may even be beyond the 20 millimeters opening, because by the time they get to the flat portion, how do you manage that?
Oh yeah, and it's like, and this is why you can't go, oh, this is my one way of doing it. You know, what you can do is put the DNARDA program on the lowers. I've done that at times. It doesn't actually have to be right in the middle. Sometimes we have a lot of patients come without any lower, without any, you know, people are very inconvenient where they lose their teeth sometimes when they want to rehab. you know, people are very inconvenient. They have mobile teeth. They have, you know, try to get the records in the stone on them. You know, it's an absolute problem-solving thing. You know, and so you've got these methods. You've got your bimanual, your leaf gauge, and like I would basket, like, I don't know what you'd call this, a Gothic arch tracing like this, and hopefully Alan will talk about the ones we do with the dentures as well. But the idea is the same, and the big pro for this is it's on a flat plane hitting, and you get the tracing, and it gives you some assurance. And they're all, you know, they've all got their merits, these methods. I'll just show you that pick your poison what you put on the flat plane. I've started quite liking this isn't but Chinograph marker. I think I got that from Finley Sun to mark on and then do your tracing with. This is this green occlude spray. But basically anything that can coat the top surface to do a trace on, and you can see you get this really nice arrow to work off. And then you
know, I'm a big fan of the black Sharpie marker. You could probably just do it and get them to just do, you know, grind over it again, and they'll probably mark into the Sharpie. But
yeah, I think I had to go with the Sharp with the composite, and it didn't come off quite as easy. Maybe it's the steepness of it, but I'll give it another bash. I would. Anything that you can rub off though is good to go. And then just this last image is, and if we could talk about this all day, I probably would. But your intraoral technique is super important, but your mounting is just as much. You've got to get all the air, all the little blebs off your casts, because they're just going to set it off. And it doesn't take a lot to set these off. You've got to be right. And then you've got to trim off these casts. These are pre-trimmed and these are trimmed. And what we're doing is we're taking every single marginal ridge and fissure area off, and we are literally just leaving the cusps. And when you put them on the cast, there should be no bounce. It should just and sit, you know. And what I liked so much, me and Alan have met on Instagram of all things, but geeks tend to find each other. And what I love when I look in is he's mounting all his cases, you know, and I'm obsessed with mounting the cases and how important it is. It's one of those jobs where I think it's cool to delegate it, but only delegate it when you have a reasonable mastery of it, you know, and because until then, you don't know if it was your record or whether it was your mounting that was the problem, you know. And once you've got that real confidence, you can be more like, no, it's the mounting, you know. And even then, to be honest, Jazz, I find that it's such a big part of it's the dentist's job. If you're doing rehab, it's kind of part of your job to get those records right. And then I would usually do 80% of the wax up myself, because the big decision is how much you're going to open them, you know, and that's only you know what all the teeth prognosis about, what could take group function. And then I'll ask the lab just to tidy it up, because I need to be better at tooth morphology. I was listening to your podcast the other day. I need to get
you're a control freak.
Control.
I said you're a control, but it's good. You need to be. It's something that Paul Tifton actually says as well, that hey, you know, unleash that control freak inside of you. When you're doing this kind of dentistry, it's actually good to be a control freak. So there we are. Hat tip to Paul Tifton.
I'm still working it through myself, Jazz, and it's very difficult to be delegating all the time stuff that you don't have a lot of confidence with. Like collaborating is one thing, but delegating it when you're working it through yourself, I think is difficult, you know. And you might sit down with the lab and work it out with them. That's one thing, but just going, you sort it when I think that's difficult. And it's totally different for us. We're in a teaching environment, and it's a huge part of their teaching is learning to do the waxing. So, you know,
I just want to say, with this photo that you have on the screen at the moment, so those listening, we've got some PVS or VPS silicon bite registrations left and right. And what you showed here is exactly the issue, that if you don't trim it, if you don't trim all the excess, all the bits in the embrasures, then it will not seat properly. And this is what they meant at dental school. When they, in dental school, when they said the disadvantage of using, I mean, the advantage obviously is accurate. And I remember reading the textbook as a dental student, the disadvantage is that it's accurate and that it's too accurate. And for years, I never knew what that meant. But when you actually start mounting yourself, and then you start putting the model, which has got its lovely blebs and imperfections, and you get this highly accurate silicon bite registration, then you realize, oh, that's what it means by it being too accurate, because you actually need to get rid of the detail. And ideally, just like, you know, in the beautiful diagram you have there, the picture there is just have the cusp tips, and that's when it'll just seat in better. I just want to drive that point home.
And a critical thing is it's got to be thick enough to begin with for you to trim it, you know. And
how thick? Talk numbers.
1.5 to 2 mils. If it's not, then you just can't trim it without it falling to bits on you. And this is why, I mean, like, you know, preaching to convert here, but we have a lot of students when they're taking an ICP record, and they will gun blue mousse around the mouth or on the teeth, and it has no place there. Because when you're in ICP, how much space is between your teeth? None. So if you have anything between your teeth, it's opening you up. You know, there's no space. So, you know, you do your crown prep, the place to put the blue mousse is where the crown prep is, just a little bit in the side. Has no place on the occlusal surface. Blue mousse is a great reg material, but only in places where you have the thickness to be able to trim it.
So a good tip, and when you're doing a single tooth crown prep, to put the PVS registration material just exactly where you've done the prep, and maybe make records of shim holds, which teeth are holding the shim, so the lab can reproduce exactly what the occlusion should be like, and then also use that sectional bite registration as a guide, and therefore you really eliminate any errors. So that's a great point. Chris, did you have any more slides before we pass it over to Alan?
No, I'm sure I've taught enough. I stopped sharing. There you go. No, thanks for indulging me.
Chris, can I just ask about the you said about the bite, putting the bite reg in, and the difficulties with doing that with that last method. Do you have them closed on the arrow point that you want them, and then in the sides, or are you opening, putting on the occlusal surfaces, and then sliding them back to where you want them to be?
I'll actually, having tried a lot of ways, I think it works. I think it works well for me with them back on the arrow. You're there. I know you're there, right? I've got the space, and I'm going to gun it from the side. Okay. And what I have to accept with that is that when I come to mounting, I just have to be quite careful to fix those mounts well. And I know we've talked about this, we've geeked on this much, but the way I do that is with using, again, this was from Frank Spear, with using a super glue and then a super glue accelerator. So I get some coat hanger, I'll cut that into bits, and then I can really quickly tack it with the glue, the two casts to get them together on the records, tack it with the glue over the coat hanger and set it instantly. And you need your mounting to be really fast, just to have it stable, and, you know, everything's stable to hold that and get that right.
Awesome. Alan, take it over, my friend. Show us some Gothic Arch Tracings, and show us a little bit of your world in terms of, anything you can add on top of Chris's awesome presentation on how he teaches and how he records CR.
Yeah, sure. Okay, so I'll just share this.
And please describe for those listening to the podcast, otherwise they'll hate you.
Yeah, of course. So I've just put up a picture of a partially dentate patient, but actually the situation is he's only got one tooth contact. And just a bit of background of how I got to this point, or this conundrum, was, I think it was, I don't know, exactly like Chris was saying, I think it's probably my second case where I came out of Dawson and I was like, yeah, I'm going to use that by manual manipulation, because I've got that nailed now. You know, I've done it once on a course, so that's going to work absolutely perfectly. And I did it a couple of times with my Lucia jig. I marked it up. I was like, oh yeah, that's going well. And then I had a patient come in that was a wear patient, 3 to 3, and nothing posterior of the 3s. And I didn't work it out until I got stuck. I got to this, I put the Lucia jig in, sliding backwards and forwards. I was like, where do I put my wax? I've literally got nowhere to put it. So I messaged Ian actually and said, Ian Buckle, like, what do I do about this? And he showed me a workaround with silicone and putty and stuff. I was like, okay. And then I started seeing about leaf gauges. I was like, oh yeah, this is quite useful. Okay, that I can still do. That might make it a bit more predictable because same as you guys were saying, by manual manipulation, it was working well on the easy to manipulate patients, but there were some I just was really struggling to be certain. You got in that opening, closing, and they're going, oh yeah, that free hinge motion. Like, is it hinging freely? I think so. I'm not sure. And there's only so long you can do that, before the patient's thinking, what's going on? So yeah, I was using the leaf gauge, but I still had this similar problem. And I hadn't really looked to resolve it until I'd realized, like I mentioned earlier, that I had this cohort of patients who were interested in implants, but for whatever reason, they weren't right for them. And so they were saying, okay, what's my next best option for multiple missing spaces? And it was a chrome denture. But I wasn't that great at making chrome dentures, so I thought I need to be. And so I went on a course with Finlay Sutton, who I'm sure many people will know is just an absolute guru of all things dentures. And he introduced me to this Gothic Arch Tracing technique. And with a bit of occlusion background, as soon as he showed this technique, I just thought, that is brilliant. It's not operator guided. The things I'd heard about leaf gauge being muscle guided, and the worries about distalizing the mandible, and I was like, I don't even know. Some people say you can, some people say you can't. Obviously that's still not answered, but I just thought, okay, this Gothic Arch, I really like the sound of that, because it's just a relaxed movement. And what I actually say to my patients is, your bite is controlled by your teeth, your muscles, and your jaw joint, and we're going to just try and take your teeth out of the equation and allow your muscles and your joint to do the work. So case like this came in, and lovely chap, and he was wearing some immediate acrylic partials, which he said he quite liked the look of, but he didn't like them covering the roof of his mouth, and they were getting a bit loose. And he wasn't suitable for implants. He quite liked cigars, and he wasn't actually that interested in implants anyway. So this was his sort of, so neck for the people on the podcast, just showing a sort of lateral view. He's only got this premolar contact, and this was as much a case of, like I was saying before, I just want to find out where CR is. It might be pretty close to where he is. I don't know though, and I'm not confident that I put a pair of wax rims in there and tell him to curl his tongue to the roof of his mouth, that it's going to go there. So I thought I just want to find out, So this next picture is actually a completely different patient, but I didn't have a good picture of my Gothic Arch setup. And again, for people on the podcast, what we've basically got is a metal pin. On this case, that's on the upper, and a metal plate on the lower. And they're set in a special tray acrylic. And this was something Chris and I were chatting about, that we sort of back and forth as to what's a good way to do this. And this was a process that I was sort of learning with my lab as much as I was learning myself. And they sent it back to me like this one day. I said, oh, why have you done it like that? And they just said, oh, I thought it was a good idea. And actually it was a really good idea, because one of the main points with Gothic Arch is that they have a stable base, because I also found this out on another case when I didn't have a stable base, and it was all in wax, the lower tracing, and it was basically a metal plate held in wax. And I thought, oh yeah, you know, I've done this Gothic Arch a few times, I know what I'm doing now. And she starts sliding forwards and backwards, and then the plate just drops onto her tongue because she's just pounded through the soft wax. Oh yeah, that's why.
So the thing that carries the plate and the vehicle that carries the pin, they have to be hard, i.e. the special tray type material, rather than the wax that you experimented with. But I just wanted to ask you, Alan, with this photo that you have here, so an upper pin, a lower flat metal plate, the tongue, where does the tongue go? Because you're totally in the tongue space.
Yeah, so one last thing just to mention there is actually the base has to be hard, but the plate doesn't have to be set into something hard. So in this case, it is, you quite commonly will set the plate and the pin into wax on top of acrylic bases. And so, yeah, that was, you know what, this was the first, because before this case, every single one I'd had back was the other way around. The pin was on the lower. And I actually phoned my lab. I was like, guys, you've done it the wrong way around, you know? And they said, oh, no. We've got a new technician who works with us from Germany. He said they do this all the time and they always do it this way around. So I was like, all right, well, give it a go.
Sorry, the thing that matters is you have a pin hitting a single point hitting a flat plane at kind of 90 degrees. Whether that's on the tooth with the composite like I did, or the D-Now program, or whatever it is, you just need that pin onto flat plane at 90 degrees to do the tracing. I think there's a Condelayer set, and they've got different ones, and I would probably have it a little further forward here, but you can do it either way, and each, you know, it's all troubleshooting with the cases. But what I love, Alan put this on, and I was like, that is genius, doing it with the special tray, because we were doing it with wax bases. It's just a non-starter because the wax, it flexes, and anything, you know, we're talking very accurate records here. So if it goes a bit, it's gone, you know. And then I started doing acrylic bases, but some even then they would like slip a little, and we would then get in the lab to put little wrought clasps on. But again, the lab hate doing that. They hated it because it was really difficult to manufacture. You know, we've been on this journey trying to find ways, and I just thought, when Alan showed me his picture, I was like, that looks really good, as long as you can get it on and off the cast, and they block the undercuts if needed, and it sits in the mouth. It's such a good idea, you know. And I suppose that other thing about getting them at 90 degrees to each other is, like, I think Finney's son, I've seen he does like a preliminary reg to help him get them, you know, that way. So it's quite nice to have them in wax, just because you can just change the angle if it was a bit off what you thought.
Yeah, absolutely. So I mean, I'm cheating a little bit, you know. I'm not showing every single bit of each case. I mean, this case is different patient to the other one, but yeah, if it's a case where it's not obvious, I will do a preliminary reg, just in normal wax rims, just to get that angle, and makes it a lot easier. The other thing, if someone's giving this a go for the first time or new to it, and their lab is also new to it, is you don't want, so the pin which goes on whatever opposing arch to the plate, you don't want it fully screwed all the way in or all the way out, because it's got to be adjustable in the mouth. And the first time I did it, I think the pin was always screwed in. And when I put it in the patient's mouth, they were more open than I wanted them to be. And I had no adjustment with the pin. So that little pin is on a screw, and it can go up and down. So you can really nicely control how open they are. So you can get them just open enough for the reg. So yeah, this case, exactly like you said, Chris, I had to chop quite a lot of this off. You know, I didn't really want them putting it around the 8s. You know, that was overkill, but you know, live and learn. And actually it fitted pretty snug in the end. And so once you've got them sliding around, so Chris, funny you said that Finley Sutton says to use China Graph, because when I went on his course, he said, "Oh, I've always used China Graph. I'm going to start trying out Occlude Spray."
Oh, I gone the other way.
Yeah, so you were ahead of the game on him. He was copying you. But so what I've got here, this is wax rims on a special tray base. So kind of like what we were saying. And you can see the green. Again, okay, for the poor podcast people, basically the plate is colored green or black or whatever you want to go with. And the little pointer on the opposing arch is going to draw this arrow as you get the patient to slide forwards, backwards, left, right. And you want to go let them slide themselves back into their protruded position. And then that arrow, you can take it out of the mouth, take the rims out of the mouth. And on the arrow, if you're watching the video, you can see there's a little disc and right in the middle there. And just off center of the middle of that disc is a little hole. So this is like what you guys were chatting about earlier with the DNRD programmer that said could have been something interesting. And those little pink bits around it is just wax that heated up to stick it in place. Again, there's probably more convenient ways to do that, but that was just how it was taught. The bottom right picture, you can probably just about see through the disc actually, that little arrow point. And so then you've got this disc, and effectively you've got a little stopper in that disc, a little hole, and the pin is going to slide into that hole. So then you pop it back in the mouth, get the patient to slowly slide, and you tell them, do it gently, because they'll knock that disc off if they're not careful. Gentle little slide in, and you just see them just go click, and then they're in. And then I'll squirt my bite registration between the teeth, because you've got a nice amount of space. And on this case, because I had some notches in the wax, it's all come out together. And then that was straight after, you just resting it all together. You can take it apart, and you can see there that again, on this case, I've got the pin on the lower, and this was before the German technician insight into how else you can do these things. So yeah, really just a lovely technique. Chris just wanted to, this was just how I do it with the this is a different case.
The image of people looking at, it's just the thing that you got to be careful with mounting is people put them together on the record, and they put like elastic bands around, or these elastic bands and things, and they're just not going to cut it, because when you're doing all your mounting and you're closing up, it just shifts all the time, and I've done it year after year and watched them, and they shift, and you've spent a lot of time, you take time on these records. And so what Alan's done here for the audio listeners is he's got these big nails, and he's tacked them to the top and bottom casts, and with the green stick, I think he used them. That's is holding them in position, but also if they move, it's going to be absolutely obvious instantly, because they're going to break apart. And no time wasted, just redo your mount, and it's fine. And you one of the problems is when the records are off, is it off because your records are off, or is it off because your mounting's off? And you want to get that mounting procedure just smooth, so you can go, it's not that, because it's really difficult when you've got records, you're like, I'm not sure they're quite right, or was I wrong about where their CR, their first contact was? Have I got that wrong in the mouth? And sometimes you got to get the patient back and have another look before you commit the, let's be honest, hours of waxing up time. And whether that's you or whether you're paying someone, it's a lot of time.
Yeah, that's awesome, and that's a very scary image, actually, seeing those nails like that.
Yeah. So we do, when I do that, I just do super glue and this speed wire, and then just a clip of coat hanger wire, like a reasonably thick one instead. And we would just, Alan's, we can have a go at it. I don't know if you tried it yet.
Yeah, I didn't get hold of the super glue, actually, that's all. I definitely was trimming my red better, but I hadn't had a go yet with the whole coat wire.
Awesome. Alan, before I just add a little bit on before we end, interest of time, any other gems you want to share with us, Alan? Because you showed something really cool. So Chris started off talking about mostly dentate patients and some of the challenges going from bimanual to leaf gauge to using that wonderful technique with the deprogram at the top and the little flowable composite at the bottom. And now you've shown us your challenges that you had by, with the lab learning how to do this, you learning how to do this with essentially a very sophisticated Gothic arch tracing setup. And we discussed about upper, lower, lower, upper, and you gave some really great tips. So if someone's going to try this for the first time, they'll remember that, hey, Alan talked about make sure it's not screwed all the way in and have a bit of wiggle room. So you're going to save a lot of people a lot of time and heartache and tears and bloodshed. So that's amazing. Anything else you want to add to that before we move forward?
Do you know, actually, yeah, I know, Jazz, you love saying, make it tangible. And the reason I was asking Chris about when he's squirting the bite regin is because what I like to do is put some cheek retractors in. And so with the Gothic Arch, because it's controlled, they're sliding into their little pin, the cheek retractors aren't going to pull them out of the way. And you can really get in there and get to the back with your gun, and you just get the nurse to hold them, and you can see so much more. It's a nice way to get the silicone into where you want it. I have done it once with, I've done it loads of times with leaf gauge, and I think one time I might have, I did it with wax rims, and I think I pulled them forwards a little bit by putting the retractors in. But yeah, if you've got a leaf gauge or a positive position that you're certain you're in, that's what I like to do, retractors, so that you can get really far to the back.
And just a tip for me is these little plastic discs. I've used them. I had a good go with them, and it takes quite a bit of time at the end of all the trace and stuff. And if you've got that arrow when you go forward and back, and you're on the end of that arrow, I'm kind of happy with that. Sometimes the whole waxing in that disc, and they can knock it off, and all these things. It's not an essential. Let's not make it another barrier to using the technique. It's helpful sometimes, but it's not helpful all the time. And all of these CR things, it's helpful sometimes. That's great, and it's not sometimes. And you gotta have a nice bag of tricks for the cases you're gonna see.
Yeah.
The main thing is you got to go out there and actually get your hands dirty and start doing this. And I mean, you guys are talking about mounting and stuff and blebs and stuff, and I'm like shuddering, man, because I'm so digital now that I don't do that stuff anymore. So
you probably don't have to, Jazz. You probably, I can see that being a big advantage.
It's great, but it's I learned the old school way. I learned at Dawson. I learned the mounting. I did that. We use a super glue. We use some metal to make sure it doesn't move. So that's awesome, and that's good to learn. But now I've moved digital. Before I talk a little bit about digital, because there's not much time left. I just I don't like the podcast episodes go for longer than an hour. But this is a really cool tip. One of my colleagues, Dr. Gurmit Hoti, he shared this with me, and he published this in Dental Update. Basically. If you want to find an easy way, and he calls it the easy peasy jig, okay? And each one, so it stands for the elegantly simple incisal platform customize. Fantastic name, right? Easy peasy jig. So essentially, it's a great name. A bit of acrylic, like trim, for example, on the lower incisors, okay? Let it set, maybe 1 to 2 millimeters. Get the patient to bite together, okay? So now the lower acrylic against the upper teeth, right? The palatal of the upper teeth, they skate around, they're pretty much then deprogrammed, and then you're able to get a second bit of acrylic and just lock in the position of the upper central incisor. And then I know some technicians who use this. I've used it a couple of times. I quite like this. The downside of this compared to some of the things that Chris talked about is that, Chris, you talked about having that flat plane. Obviously with this, you don't. Now, I'm sure you can temporarily bond some composite onto the upper, but who wants to do that, right? The whole point is want to be easy and quick, but I just want to share that one little interesting way, and you can read about that more on Dental Update. You showed some really cool Gothic arch tracings, guys. Let me see. So this is a splint patient of mine, and you can see she herself has made the Gothic arch tracing for me, and what we're seeing here is not the sort of the tracing of the patient in the chair. This is the tracing that someone produces during their parafunction. So sometimes you can use a splint, you can color it in, and your patient, because here's the beauty of it. There we are. You've got the lower point, okay? You've got the upper flat plane. So this is no different to what you were doing, Chris, in the chair, except I'm using this to protect them as a protective appliance as well. But I could totally then use this as a diagnostic appliance and actually get the patient to sit on that apex of that triangle and squirt some bite reg material in, using the sort of Alan Burgin way of moving the retractors, moving the cheek out the way using the retractors. So that's another way. And there's a cool little photo here as well, just to show it in action. And we talked about the master, but I just want to finish up on just touching on one last thing. Any questions about those few things, guys?
I think that's brilliant, actually. And I had a friend recently asking for some advice on a case, and he said, "How can I make this as easy?" And my patient doesn't believe that she grinds. And I was like, get them in a darcer, prove that they grind, and then it's only covering whatever it is, 3, 3, 4 to 4. And then you just guide them back onto the tip of the arrow, and you can use it for your reg as well. Yeah, I think it's a great technique.
And look at that, anyone who's still there going, they think they've got to set up immediate side shift and stuff. There's no immediate side shift. The arrow is telling you what's happening in the mouth. Immediate side shift's been shown why people think that, and I really don't subscribe to that. And then we haven't talked about a really important method of doing CR records, and that is very like what Jazz is showing there, which is the Cloister programmer. And what that really is you're creating an appliance that gives you a stop in the front anteriors that the patient go away with for really difficult patients. And the key difference, I suppose, is that it's made in such a way that the occlusal surfaces are free, so that when you do put that bite registration material on, you can mount the casts. And the biggest thing with the Cloister programmer is CR records is fine, but the biggest thing is that you can then start to cut down the little stop on the front, and that is amazing for doing equilibration, which we're not doing too often when we're opening these cases. But if you do have to equilibrate a bit first, you pretty much your options are that or a leaf gauge. So it's the most controlled way of doing that.
Awesome. Well, we don't have time to talk about digital, but I'm going to whet everyone's appetite. But I'm going to whet everyone's appetite because Ian Buckle, I've recorded with Ian already, and he talks about his new digital course. And we also talk about some hints and tips about doing it all digitally. So I'm going to keep you all in suspense for that. I'm just reading some of the comments, the live comments. Richard McKinder, he said that at one point about 40 minutes ago, he said, "I think what Chris is talking about is why it is important to check the patient feels no tension or tenderness when squeezing down on the leaf gauge." And I think that's important. I'll let you touch on that, Chris, in one moment for people who've never used a leaf gauge before and why that's important. And Lee Nichols also said you also need accurate impressions, which is of course a foundation, a cornerstone, good accurate impressions, as well as the record, as well as the mounting. So these are the fundamentals. A point well made. Chris, just tell us, finish up on the podcast about why it's important not so that your patient's not feeling tension when you're using the leaf gauge.
Yeah, so the main thing is, the idea is if you're in CR and you load test, the fact that they're not in pain generally tells you that the joint's okay, that the disc's in the right place, and that they can accept the load there, and that they're back in centric relation. So if they are getting tension, then it probably is pushed it could be too far back, or they've got like a disc derangement or something like that. I mean, either are troublesome for treating them. I think on an even a reasonably high level of treating people, if you can't get rid of that tension and you can't fully relax lateral pterygoid, then they're a risky group of people to be treating. And would you say that's a fair thing? It's not just one reason why you might fail a load test. There's sort of a few there, but generally it means either you're not quite in the right place or there's something not quite right with their joint.
Their muscles are just not happy at that point, and that's where I like to give them a splint and let things have a bit more time. And only once they're pain-free, tension-free, sometimes the lateral pterygoids can just give you a bit of tension when you've got that leaf gauge inside. And one trick that actually Stephen Phelan taught me on his course, Occlusion Design, is you give them some cotton rolls, you get them to bite together on their back teeth, right? And that activates the master, the medial pterygoid, the temporalis. And because those elevator muscles are now firing, it just gives that lateral pterygoid a bit more impetus, a bit more oomph to just start relaxing. And sometimes that actually worked immediately. So that was interesting, Stephen Phelan's way of teaching that.
If it's in spasm, you just can't get it. If it's in real spasm, you're just not going to get it to fully relax.
That's not your day to record. That's not your day to record.
Yeah, and yeah, I think you know, and I think when you do this Gothic arch trace, if your arrow is bang on, you're you're really confident, you know. But if the arrow is looking all over the place and stuff, you know, and you're getting these points that are going past where the two lateral lines cross, then, you know, something's not quite right there as well.
The really nice thing about it as well is you can see in patients when you put it in, you know, when you start using a leaf gauge and you say, oh, you have a little clench on it, and then as lateral pterygoid relaxes more, your number of leaves might change or whatever. With the Gothic arch, as they're sliding, sometimes you put it in and they start sliding and it's like not really going anywhere, and you just leave them and you just keep sliding back and forth, you know, and actually you just watch it all just happens for you, and you just see this sliding motion get easier and easier, and that's quite satisfying when it works.
Awesome, gents. I've just had a thank you message from Joe Harvey. Joe, thanks so much for watching. He's really enjoyed it. Some great tips in there, so he liked it. Some of you join us on the Protrusive Dental community, where we've got, I posted a few videos. Alan, you knew this educator already. He talks about leaf gauge in a cool way as well. Join this community because good eggs like Chris O'Connor and Alan Burgin are on there as well, and they're just great people to learn off. Chris shared his papilla management paper on there, which was just top notch. But gents, thanks so much for coming on the show today, for really showing your true geekiness. I really like that. I mean, at some point we were laughing in this episode, and really we shouldn't be laughing about some of the things we were laughing about, but because we're so nerdy about this stuff that we actually got enjoyment out of it.
This is a very nerdy, this is like, I don't know, if you're not really doing rehabs or I think it's quite niche, you know. I'm afraid it might be a little niche, but when you start and you get into it, maybe you have a little listen again. You know, we're all just figuring out a way that works for us and trying different things. I think that's the thing I've learned, and the patients you're doing it on. Sometimes, you know, there's such difficult patients for various reasons. You know, mobile teeth. There's a whole different chat. You know, there's so many things. You've got to be really flexible with your approach. It's not just as it is on a course where you just do it on other dentists who've got fully dentate teeth. You know, there's just so much more to it when you're doing it lots. You know.
It is.
Guys, I'm going to just stop the live stream in a moment. Any last words, Alan, before I stop the live stream? Then we'll have a little chat.
I was just going to say, I mean, it is niche and nerdy, but I get some of my friends see my posts and like, mate, come on, you know, have a lunch break. But it's the foundations to the beautiful aesthetic stuff. You know, if you don't want your veneers to chip, you want to know where their bite's going, and it's the foundations to make a bit of a less stressful life.
Do you mind if
well said.
Do a shout for my
no, please do. So Chris, you know, tell us about Incidental Limited, because this is where we get, as a practice, we get our Tor VM matrix bands from. And just on that note, Mashek, the magician, is going to be on the pod. He was recorded already. You might have seen the teaser on Instagram. Fantastic episode talking about how to get the right seal, and a lot of the matrices that he uses as well are Tor VM, which is I think it's a Russian matrix, isn't it?
Yeah, that's right. Mashek's I'm a massive fan of Mashek, by the way. I'm super excited to listen to that podcast. Really am. So I like it. You know, the best way to advertise my new business is to do a talk about something that's not related at all to the business. Records. So, but, you know, we set up maybe just before the pandemic, which was brilliant timing. Basically, what we do is we are the UK suppliers of Tor VM. And Tor VM, I think, already has a good name in the UK. They're a fantastic matrix band. They do rubber dam kits and abrasives, really good value, really good quality. They're actually my favorite for a very long time, regardless of price, but they're also really well priced, so that's excellent. And there wasn't a UK supplier, you know, and I ran courses teaching matrix and rubber dam, and I'd see like, these are great, but where are you going to get them from? And it was, I know, eBay. Difficult, you know. And the market on eBay just got absolutely flooded with fakes and, you know, counterfeit stuff. And we were like, we just wanted to do something about it. So we set up, and it's been quite a steep learning curve, learning a bit of distribution and stuff. But we've got I've tried to put as much stuff as I can around me. So we're on Instagram, Facebook, and we're selling them at hopefully really competitive prices. We're run by dentists. We're trying to get the best products. We select from their catalog that we think are mint, and we hope to show you how to use them really well. And we're just geeks like you who love this product. So hopefully you go and have a look. You know, it'd be great to you know, to start using them, but I genuinely love them, and that's why it's been really nice actually bringing them over. So thanks, Jazz, for letting me put the advert there.
No, I'm glad you did, because Tor VM, I've been using it for years now, and I absolutely love the matrix compared to, I use all the matrices. I use all of them because, and we're going to talk about that in the episode of Magic. There's no one magic matrix, but a high percentage of the time I'm choosing the Tor because of the stiffness, because of the contour, and even then you've got the soft and the hard, and maybe we can go into deeper into that one day. But that, you know, thank you so much, Chris and Alan, again for the second time we spent some time with you. Thank you so much for coming on, gents. I'm going to stop the live stream and we're going to have a little secret talk.